which is where I met Tim Lee and Loic Fabricant, which is how I ended up here. Then I went to Boston at Harvard for my fellowship, back to Texas for 3 years, and then now I've been here for almost 2 years. This pregnancy and trauma kind of became an interest of mine when I became pregnant, and then I myself had a pregnancy complication not related to trauma, but I had something called HELLP syndrome, which I think there's some other L&D nurses in here know what I'm talking about. Very scary thing, delivered my son at 30 weeks, and I became kind of an advocate for pregnant patients about, what does a NICU stay look like if you have to deliver early? What are safe breastfeeding medications? When do you actually need to pump them up? All that sort of stuff. And I also knew a lot of the NICU nurses, so I could get our trauma patients breast pumps if needed. So this kind of became an interest of mine. This is a lecture I actually gave to the OB residents at my last job. All right, so we're going to talk about the epidemic. I tend to move around, so if I'm blocking, so just let me know. So we're going to talk about the epidemiology of trauma in the pregnant patient. We'll talk about the physiologic changes that happened to the woman's body during pregnancy, and we'll talk to the approach to the pregnant trauma patient, which is basically the same. We do the ATLS, we have TEG here now, which is great. We'll talk about imaging, and then we'll talk about specific pregnancy-related traumatic injuries, and then the indications for an emergency section. So epidemiology. So trauma during pregnancy, it affects about 6 to 8% of all pregnancies. Most common causes are going to be your domestic violence, MVCs, and falls. These are most commonly blunt trauma, which is what we see the majority of here anyways. Potential consequences, obviously mom could die, fetus could die, or get injured. Miscarriage, placental abruption, which is emergency, preterm labor, and then plus all the normal trauma injuries that we have to think about. So 1 in 4 pregnant patients admitted with trauma during their 3rd trimester ended up having to be delivered. This was an older study. This is a retrospective study in California. So 10,000 pregnancies that required hospitalizations due to trauma, 25% delivered in that initial hospitalization. But even if they made it to discharge without delivery, they had significantly increased risk of preterm birth, low birth rate, and abruption. So there was a study here that was a retrospective study done that specifically looked at MVCs and then our ISS scores, which is an injury severity score. It's calculated generally after discharge because it's based on injuries and coding. 83% of the people were discharged without requiring delivery, but they had continued risk of adverse pregnancy outcomes, which is consistent with what the California study saw. And ISS was a poor predictor of pregnancy outcomes because it's more just a trauma mechanism and doesn't actually account for pregnancy changes or trauma related to pregnancy, like placental abruption. That's not something we can score within our ISS. It doesn't really include pregnancy stuff. So let's talk about physiologic changes in pregnancy. Can anybody say one thing that changes during pregnancy? Increased blood circulation. Yeah, your volume of blood changes, right? You get a relative anemia because your plasma is increased. What else? Squishing of organs, absolutely. Anything else? What do you always hear, kind of what's the common thing about offloading the IVC? You guys familiar with that? Don't lay them flat, put something over that right side because that grabs the uterus. So let's talk about some of the changes. So displacement of the intra-abdominal organs by a gravity uterus. So that we think of the uterus as a pelvic organ, right? It's protected by the pelvic bones, but after 12 weeks, it actually comes out and becomes considered an abdominal organ by that time. And that's when you can start to see compression of the IVC. That is important because you compress the IVC, that's the big vein that returns all the blood flow from the lower part of your body back to your heart. You compress that and you can see a cardiac arrest because you have cessation of all blood flow. So this is just a little diagram about showing how high that uterus can get. And so we can talk about about 20 weeks, you're at the umbilicus, and then by near term, you're almost at the diagram. So the increased blood volume and relative anemia. So our patients who come in as trauma and we get those initial labs, I wouldn't expect a woman to have a normal hemoglobin of 13. They're more likely to have one around 11. And that's normal. That doesn't mean they've lost any blood. They also have a decreased functional residual capacity, so that means that they can't expand their lungs as much because of the compression from the uterus. They can't push their diaphragm down. And And so they actually have increased oxygen consumption because they're having to take smaller breaths. So something else that's interesting is they have decreased lower esophageal tone. So that becomes important when we talk about intubating patients, right? And the risk of aspiration goes up. That's why a lot of women experience heartburn. It's not just that everything is squished, but that lower esophageal sphincter is more prone to be open, a lot more reflux. Other things that you can see is this becomes more related to trauma. It's going to be dilated pelvic vasculature. So people who come in with pelvic fractures are at increased risk of exsanguination. So we already talked about pelvic fractures, how scary they can be because they got a lot of bleeding, we got to go to IR, it's not something we can really handle very well surgically. So in pregnancy, those vessels get even bigger, so they bleed even more. This is just showing some types of pelvic fractures. So this would be considered open book. This definitely is. So is this one. This one is vertical shear, which also has a high risk of bleeding. These lateral compressions aren't quite as bad. But anything with widening of pubic symphysis for fracture vector tends to be bloodier. There's also increased uterine blood flow, but this is not auto-regulated. If you cut my arm, my body's gonna sense I'm losing blood and start clamping down those arteries. That doesn't happen in the uterus, which is why a lot of women have postpartum hemorrhage because the body doesn't automatically start to clamp those down, and often they have to give things like oxytocin to kind of trigger the body to start clamping down on those blood vessels to prevent hemorrhage. And then just remember that maternal hypotension can lead to fetal hypoxemia, which can cause bad outcomes. So how do we take care of a pregnant trauma patient? So here's our trauma alert. So at last institution, they were 911s, which are full activations, or 922s, which have been your moderate activation. So this was a full activation. She's a 28-year-old female. She's 30 weeks pregnant. She's restrained driving an MVC. Her blood pressure is 98, heart rate's 110. She's coming here in 10 minutes. What are you guys, as the nurses, going to be thinking about and doing? One, I'd say call OB, right? This is a viable pregnancy. What do you guys know what viability is? Roughly 24, I don't know here, maybe 24, 25?
Call it 24.
24 weeks. So every institution is a little bit different. So basically, uterus above the umbilicus, personally, I'm going to be calling it OB. Because maybe the mom's not going to be able to tell me how far along she is, but that's approaching viability, and I'm going to want their input. I would want OB aware patients coming in and want them down. I probably have NICU aware that, hey, we got a trauma patient coming in, she's hypotensive, she's got a viable pregnancy. We may end up needing to do a C-section on this woman. I would make sure, and also if we have to do that, we have to deliver this baby. I don't know how to resuscitate a neonate, especially a preterm neonate. And so we need to make sure we have somebody in the room that knows how to do that. I would also, I know there's a warmer that we keep by, like gathering all those things. And if we don't have them in the room or outside the room, at least knowing where they are and maybe having a runner that say you or the person that has to gather all these things if you hear that we're doing a C-section. What I would be doing is having my partner with me. This is not a trauma I want to run by myself because a lot of things can happen. As nurses, you're going to want to have a lot of support. So I know we have a lot of things here for pediatric stuff, but you know, I would want the level 1 up. I want to make sure that we have something that we can bump this patient, put a bump under them so that we can offer the IVC, all those sort of things that we need to be thinking about. So we do follow normal ATLS. And our focus when a patient comes in is maternal life, right? If mom dies, fetus dies. So you have to focus on mother first. And so that is what our primary survey is still. So we still do airway, breathing, circulation, and disability, just like we would for any other trauma patient. Although part of this circulation is going to be making sure we put that bump under the right hip so that we can offload the uterus. Secondary survey, that's going to be the remainder of our head-to-toe exam. Here is where we'll throw in some of the pregnancy stuff as well as our individual. So in most EDs, you know, the airway is going to be done by our ED providers. In pregnant patients, we need to have a lower threshold to intubate them. Generally, if they're SAT below 95, you should intubate that person because you are getting less, could be a sign of less blood flow to the uterus, to the fetus, and causing fetal issues. they won't show hypoxia as well. We talked about the risk of aspiration with the decreased lower esophageal sphincter tone, and they also have increased airway. So overall, going to be much harder to intubate. Glad this is not my job. Breathing, so listening for breath sounds. Remember that uterus is going to be displacing everything, and so things are going to be squished up. So listening for breath sounds in the anterior fields are going to be real important. When we are placing chest tubes, we're going to need to make sure we are staying really high, because you can go into the abdominal cavity, because your diaphragm is going to be much higher up. Can anybody see the pneumothorax from this X-ray? What side is it on? So this is right side, this is left side. Yeah, here it is. All this is air, and this is the crumpled lung. You actually have deviation on this. Is your airway deviation? So this is actually tension in the thorax. And that could be gastric bubble, that could be air in the diaphragm. Who knows? Circulation, check pulses. This is one where I probably go for carotid pulses less so than thermal pulses, just because the compression that you get down there. Don't forget to bump the patient onto the left side to off of the IVC. Aggressive transfusion in these patients. We want volume over vasopressors and blood over IV fluid. And this is for all trauma patients. And remember, CPR is ineffective in trauma. What is the most common cause of traumatic cardiac arrest? What? Speak up. What is it?
Blood loss.
Right, yeah, it's blood loss. So it's hemorrhagic shock. CPR is not gonna, you can pump the heart all you want, but if it's empty, it's not gonna do anything. So the priority is getting blood back into these patients. And that goes to, that's true for pregnant patients too. And then obviously you can't have a direct cardiac injury that can cause cardiac arrest, but that's gonna be much lower on the differential, less likely to happen for those traumas. Disability, if they need a cervical collar, put one on, we'll calculate their GCS. You have to have a seizure, this is where it can get a little tricky, right? So did they have a seizure, have a car wreck? Was that because they actually have a TBI, or are they eclamptic, right? So that is something that's also nice to have OB on board and be like, I don't know, I'm not really seeing any signs of severe trauma, and then maybe we get a blood pressure that's 180 over 100, and like, oh, maybe she's actually eclamptic, let's give her some MAC. So secondary survey. So the remainder of the head-to-toe exam, really important, you know, is going to be the abdominal exam. Adjuncts that we're going to do to our normal is palpate the fundal height. If mom can tell us how far along she is, that's great, but if she can't, then we kind of have to just go based on what we can feel. In larger patients, that can be really hard to do, but we just try to do the best we can, and that's really just assessing for viability and how aggressive we need to be on getting OB involved. Check for uterine tenderness. So if they have a tender uterus, that can be a sign of uterine rupture, and that may be your only sign until mom gets super sick. And then peritonitis is going to be more difficult to detect because you have a band like this, right? You're trying to detect peritonitis in. Fetal heart rate. So some places, my last institution, we did continuous fetal heart rate monitoring if they're greater than 24 weeks for at least 4 hours for all trauma patients that came in that were greater than 24 weeks. If there were any sort of concerning features or they had any sort of obvious abdominal trauma like a seatbelt sign but maybe no injuries that we noted, then they got 24 hours of continuous monitoring. I don't think we have a guideline here, so it would just be talking with our OB colleagues to see what they feel is most appropriate for that patient. And then also vaginal exam of these patients, you know, if we're certain noticing a gush of fluid or there's bleeding, those could be signs that maybe we're in preterm labor, we have water rupture, or we have abruption, or we have a uterine. You know, so there's a lot of signs that go into this that can key us into something more going on. And then there's this focused obstetric history. And this is a good thing for you guys to know too. Have you guys heard about this, the code? So like, have you had any complications with pregnancy? What is your obstetric history of provider? What is your dating method and your due date? And then event details, like have you been having any of these issues? Like if mom can tell you this is great. Obviously if mom's intubated or super sick, you're not gonna be able to get this information. But if we're able to give it, this is really good to help us. All right, so back to our case. All Alright, so we do our primary survey, her airway's intact, she's got breast sounds bilaterally, she has weakly palpable pulses, and she's GCS 15. She's still hypotensive, tachycardic, and she's a little tachycardic. Our secondary survey, we notice abrasions to her lower abdomen, seatbelt sign, and an unstable pelvis. She's got a left arm deformity and a scalp laceration. So automatically, what are you thinking? What?
Pelvic binder?
So it's gonna be a little hard to get a pelvic binder on, right? Even though you put it on the greater trochanters, right? Which we always put our binder right, it goes here. But even with a gravid belly, like you might not be able to get that on. But bleeding, right? Like she's hypotensive, we have an unstable pelvis, we got an arm deformity, scalp lax can also bleed really, really bad. So this is where I'd be like, maybe we need to be getting some blood. Let's start thinking about that. So if I was running this trauma, I would go ahead and hang some plasma and some red cells. And probably run them into their rapid infusion. Alright, so next step. Presumed injuries, pelvic fracture, left arm fracture. Is she in hemorrhagic shock? Yeah, technically she is. Yeah, her shock index is greater than 1. So you guys know what shock index is? Heart rate greater than systolic blood pressure. So if that, if you divide them and it's greater than 1, then that's considered a sign of pretty severe trauma. What do you guys think? Is she a tourniquet? Right? You know, there's nothing, right? She's got an arm deformity, but she doesn't have bleeding. Nope. Probable only external signs of bleeding is going to be a scalp laceration. Can't tourniquet that. What about packing? You could have a scalp lac, right? Yeah. Pelvic binder? Yeah, maybe. And then I put a little bit in here about Reboa. Is anybody familiar with Reboa? We don't do it here, and I'm not a fan of it. Do what? Yeah, there you go. Yeah, those of you who watch the PIC, yeah. It's still pretty controversial within trauma surgery, but it has some, it actually is pretty good in this type of situation where you really need more time to figure out what's going on. We'll add some more slides on that here in a second. So we give her a unit of blood. It helps her blood pressure, it helps her heart rate. So Reboa, I looked to see, because I think Reboa would be great in postpartum hemorrhage, right? Because you just have these pelvic organs that you need to help cut the blood supply off. In trauma, sometimes we're guessing kind of where to place it. So in cases of accreta, which is where the placenta grows into the uterus, it can sometimes go into like other abdominal organs too. There are case reports of them putting these in preoperatively so that when all the bleeding starts, because these patients usually have planned cesarean sections, often with a hysterectomy, and they have lots and lots of blood loss. And they usually do them early, so they do temporary reviews at sometimes between 34 and 37 weeks. So they place them preoperatively to try to help prevent some of that blood loss. It can be used in pregnant trauma patients. It allows time to get to the OR, and it kind of gives time to catch up. You know where to place it if you're worried about pelvic fractures. It's the lowest one, but you do risk cutting off some blood supply to the uterus if you get it in the wrong spot. This is what it looks like. So it actually, it's a rapid endovascular balloon occlusion of the aorta. That's what it stands for. So this goes in the femoral artery right here, and then you can instill this balloon. It's got markers you have to do it under fluoro so you know where you're getting it. I'll show you what the different zones are depending on what you're trying to do. You can run, obviously, an art line off of it, and that's where you're balloon. But it basically includes your aorta. It does the same as clamping that we do during the thoracotomy, but you can do it much lower. So these are the different zones that you can do. So when we clamp the aorta, we clamp it here. We are thoracotomy, right? So anything down here is not getting blood supply. Here's your liver, your guts, both your kidneys, more of your guts, not getting anything. Guts are very sensitive to blood supply, so they need that out. You can, some traumas, you can place it here just below the renal arteries. This is kind of what we talk about. Or actually, this is kind of in the zone 2, so if you're worried about like a renal artery injury, then you can put it here, and it won't do the renals, but most of us don't have gut. But honestly, when people bleed out, it's from the spleen, which we call the celiac trauma, and less likely like your gut organs, like your colon or your small bowel, sometimes the liver, which is also up here. So most people will place it here, or pelvic, which goes down here. For pregnant patients, this is where you want to place it to help with pelvic bleeding, with pelvic fractures.
Do we have those available?
No, and I'm glad. I don't actually like them. I've never placed one because it takes a long time to place, right? You have to use ultrasound, you have to get a stick, you have to do it under fluoro. We're actually pretty good about just getting people to the OR. I think this is good in places where you're not sure the patient needs the OR or your OR is not ready. But there's still a lot of controversy. You know, my last job I was there for 3 years and we never placed a single one because we always could get to the OR. Other places like to place them in everyone, regardless of whether or not they can go to the OR, but it's not without complications and risk as well. So imaging. So our patient, what kind of imaging do you guys think we should be doing? We're gonna order a 6-pack, maybe a CTA neck on that with max space, anything? Mom takes priority, right? So if we need imaging, get the imaging, right? MRIs take too long. We can do our fast. It's a little bit harder to do and not quite as sensitive in pregnant women. But this is what an example of a positive fast looks like. This is a focused assessment of sonography and trauma. So this is what a positive fast looks like around the liver, so the radical quadrant. So this is the blood right here. This is liver. This is kidney. Here's your spleen, kidney. There's fluid there. That's your diaphragm. That's actually fluid in the pleural space too. So those would be positive fast. Hypertension plus a positive fast equals an OR in the trauma world. Blood test. We're going to get all of our normal blood tests. We have TEG now, so make sure we're getting a TEG. This is that fancy antibody test, you know, to make sure that like mom's blood type and baby's blood type are compatible. So how does everybody feel about TEG? Comfortable, not comfortable? Want to know a little bit more about it? A little bit more about it. Okay. So I'm a huge proponent of TEG. So I like it because it's a qualitative measurement of the ability to form clot in blood. And it looks at everything. It looks at your coagulation factors, your platelet function, and fibrinolysis. We don't have another single test that does that. And you can watch it in real time. Like I can bring it up in the computer and watch it being ran and have really good information in 10 minutes. And it guides resuscitation by telling me, okay, based on this, I need to give platelets and not follow just standard MTP, and it saves a lot of components. So here's what traditional TEG looks like. Ours looks different because we actually have TEG 6 now. But you know, this right here, this is called your R time. This lets you know if you need clotting factors. So if this is abnormal, you give FFP. Here, this is going to be either platelets or fibrinogen based on which one of these is off. And then it also tells you thrombolysis, so or fibrinolysis. So here, you see this coming down like this over here. That means we need to get TXA. So it's kind of cool. This is what the curves look like. Although we don't really follow this anymore. Now it clearly pops out and it says give platelets. Give fibrinogen. So there's not as much thought into it, but it's still nice. And we all know the pregnancy, you're at risk for DIC, so something like this here. But it's still a really cool test and I like it. So going back to the imaging. So chest pelvic x-ray, CT imaging, in this patient, I would get everything. You know, maybe not a CTA of the neck, maybe not a max space if they didn't need it, but I would do a 6-pack and probably a bladder delay, because a lot of, especially with the seatbelt sign and the gravity uterus, you get more compression of the bladder and you have a higher risk of bladder function. But everybody was worried about, oh my gosh, radiation to the fetus. One, they're out of organogenesis because she's 30 weeks along, so radiation is really not going to have that much effect. And what do you think they're going to do to that fetus as soon as they intubate it? They're going to x-ray it, right? So this talks about like the doses, the radiation doses of all these tests that we order. And so they're not that bad. You know, like here your abdomen pelvis is going to have your highest, but still, that's not that bad. So then, you know, the naturally occurring background radiation is almost 0.1 milligray. And so it's quite a bit higher, but just to save mom's life or save Sweetness's life. And then obviously X-rays of extremities. MRI is rarely used in the acute setting, but let's say mom has some uterine tenderness, she gets admitted, she's getting fetal monitoring, OBs are worried about something, they then may request an MRI in an urgent manner, but not in an emergent manner. So that usually won't happen while they're in the emergency department. So here's just what some CT images of trauma look like. So here's a splenic laceration here, this is a liver laceration, just to a spleen, this is a very full stomach, liver, and then this is liver here. That's stomach and pylorus, and then that's kidney starting to go down. This is what extraperitoneal bladder rupture looks like. So this is regular bladder delays. Here's bladder, and then you can see all this contrast out there. And then same here, here's bladder. This is actually a pregnant patient, right? You can see little spinal cord, little baby bones, and then you can see that extrapolation contrast there. So just what some CT heads look like. That's what a scalp hematoma looks like on a CT head. And then this is what intraventricular blood looks like. And then this is AO dissociation, also known as internal decapitation. It's really hard to see on X-ray and CT scan, but you can see like this right here should be sitting flush in here. It's not. So this is that internal decapitation. All the ligaments through that and included. And then here too, so this is C2, this is no longer on, so this is C1 and no longer on C2. So you can widen this space here as well. This person likely is going to be severely debilitated or not survive. Alright, so let's talk about pregnancy-related traumatic injuries. Alright, so placental eruption is one of the big ones. So that's where the placenta pulls off from the uterus. It can be partial, it can be complete. It has a 67 to 75% fetal mortality rate. Happens about 5% of the time in minor trauma and 50% in major trauma, right? Who's to say what's minor versus major trauma? Really the only signs sometimes are just uterine tenderness, vaginal bleeding, and then maybe you don't get reassured fetal heart tones, which shows some sort of distress to the fetus. But there's also ultrasound, which is not very good, can have a false negative rate of up to 80%. So it's not always good to look at the placenta that way. So this is what normal placental imaging looks like. I had never seen a CT scan of a normal placenta, so the first time I got a pregnant trauma patient, I just walked over to radiology and I was like, this doesn't look normal. And they're like, that's normal. I was like, are you sure? That doesn't look normal to me. And they're like, how many have you seen? I was like, okay, this is my N of 1. But this is completely normal looking placenta, and then obviously there's little baby bones here. And again here, where the placenta can be adherent in different places in the uterus. And then these are just some sagittal views. So you can see normal placental imaging. Versus now these are abnormal. So these dark areas are all devascularized placenta. So here you can see little stripes through here, which I found out is generally how it presents is you get more of a cracking and not just a full breaking off. It kind of cracks apart, so you get what they call trabeculate. So this is the only part of the placenta that is getting blood flow, are these lighter parts. And then again, just some, it's like really, you're not seeing much. This is a good one, because you've got a little bit here, but all this is devascularized placenta and it's pulled off. Alright, uterine rupture. We had one of these when I was at my last job. I was not on call, but being in Texas, we had a lot of tornadoes. This woman was in her trailer house. She was 5 months pregnant. Whole house got picked up. She got slammed to the ground and had uterine rupture. She ended up losing her fetus, which was kind of traumatic to everybody because she ended up having to go to the OR for a C-section, but it was because the fetus had fetal demise, not because of her traumatic injuries. But it's hard to pick up. It doesn't happen that often. It takes pretty significant trauma to rupture the uterus. You can imagine this is a thick muscle, right? It's what its job is to grow, get really big, and then using its force to force, a 7-pound baby out. So that's pretty amazing. almost always, like nearly 100% mortality for the fetus, because as soon as the uterus ruptures, like, just things go bananas, right? There's nothing there to protect that fetus anymore. And up to 10% maternal mortality. I think you often hear about uterine rupture in the setting of induction and oxytocin. This is related to traumas, so I'm not speaking about those rates at all. And then when it comes up to maternal mortality to uterine rupture, it's usually due to their other injuries. It took so much force to rupture their uterus that they also had other significant injuries. And again, ultrasound is not very sensitive. You know, you may have a positive FAST, but who knows what that means, right? It's oftentimes discovered in the OR. I guess they say here you can have absent fetal heart tones, but sometimes you just don't know if you're not getting it, it's not in the right place. But these patients are almost always going to be going to the OR for other reasons as well. So these were some examples of uterine rupture that I would not have picked up on. Maybe here you can see, right? So this is supposed to be the uterus right here. You can see this doesn't look normal. There's some abnormality here. But here they're supposed to be pointing to like the uterus doesn't look, I mean, it looks intact to me, but I was like, it can be very hard to pick up. Or actually, no, that's what this one was. This is actually, that is not the uterus. This is the fetus outside of the uterus. It's just a portrait of the CT scan. All right, so back to our case. All right, so we got our chest x-ray, pelvis x-ray, we did a FAST, we did our CT. Now our blood pressure is 80 over 50 and heart rate's 35. What do we want to do? Yep, we're going to give more blood and repeat our ABCs. Right. Now, blood pressure is 60 over 40, heart rate we can't count, and she's unresponsive. So what are we going to do? Right? We're going to crash intubate, and we got to start thinking about, do we have to do an emergent C-section? Does anybody know the time from heart stop to having fetus out? 5 minutes. Yep. So, I mean, by the time you make that decision, you have stuff 1 minute. You know, like the term that you're about to cut a baby out of somebody. So maternal indications, so mom comes in, there's loss of maternal pulses, uterus is above the umbilicus, get baby out, right? Have ED work on airway while you're getting fetus out. Fetal indications, so non-reassuring fetal heart tones. Again, this is only past viability, so uterus above umbilicus. I know we had a non-trauma related emergent ED C-section, but I'm sure it was pretty traumatizing for a lot of you guys. I'm sorry that you guys had to go through that, but it sounds like everybody did the right thing, which you should be proud of yourself for doing that, because this is a really hard decision to make, to do this. All right, other reasons, sometimes if we're in the OR and we need to look at the maternal traumatic injuries, we'll call OB in to say, hey, you're gonna have to get the fetus out because I can't assess these pelvic fractures, bladder rupture, you know, maybe there's an aortic injury I gotta get to, and I need this uterus out of the way. And then in burns, which we don't do here, but if they're in the 3rd trimester and they have greater than 50% total body surface area, then you should be doing an emergency section. So these were some studies that I found where they looked at pregnant women admissions at 9 level 1 trauma centers in the US from 86 to 94, so quite a long time ago. But there were 441 pregnant women and they had 32 emergency sections. They had a 45% fetal survival and a 72% maternal survival. What they found was that the fetus was viable when they were greater than 26 weeks and they had fetal heart tones. They had a 75% survival rate. And granted, this is data from 30 years ago. So now with better technology, I imagine our survivability is much improved. So I was going to tell you about this case. So when I was interviewing for fellowship back in 2018, I was in San Antonio, which is where I went to med school, and they were taking us a tour and all that sort of stuff. We're down in the ED, and they shuttled us out, like, we're getting a trauma in, you guys have to go somewhere else right now. And we found out later what had happened was the trauma that was coming in was a woman who was probably about 36 weeks pregnant. She was at a bus stop, and the car ran a red light, ran into that bus stop, and she was coming in as a full trauma activation. Got to the ED, she was talking, able to say her name, say how far along she was, all this stuff, and lost pulses in the ED bay. So the trauma surgeon, who has, San Antonio has a lot of military people, he had a military background, he immediately did a C-section and had the fetus out in under 2 minutes, while one of the other fellows was doing a trauma thoracotomy, a resuscitative thoracotomy, where they found that she had a rib fracture that had punctured her pericardium in her heart, and she had tamponade. And so they were able to empty the pericardial sac. Her heart started beating again. And this is our case, my bad. We intubated, we did roboto, we took her to the OR. We did our big case. We did our splenectomy, we did a packing of the liver lag, and then we couldn't get hold of the bleeding in the pelvis, so we had to come to an emergency section, where she had an intraperitoneal bladder rupture and pelvic fracture. So this was our fake case. This was the real case. But this is them 10 days later. So they both survived. And she had best case scenario for blunt trauma and ED thoracotomy survival rates. You have something small that's fixable. And she didn't have any other intra-abdominal injuries. But yeah, this was 7 years ago now. So people do survive. So what we do matters, even sometimes if it feels like what we do doesn't. So takeaway points. Maternal life is priority. It's hard to focus on that, especially when you know like there's a fetus there, especially if you're a parent or you are pregnant. It is extremely difficult to not think about those things, but you have to remember mom is priority, because if mom dies, fetus dies too. Hypotension is hemorrhagic shock until proven otherwise. Please give blood over IV fluid. That's really important in our trauma patients. Do the CT scans. Question?
Yeah, I'm just curious. If the mother was found down and like EMS brought up doing CPR for like 20 minutes, like in the case that happened a while back, are we still, as soon as they get there, are we just starting a C-section right off the bat?
Yeah, I think you have to, so I would not do a ED thoracotomy or resuscitative thoracotomy on that person because they were found down in 20 minutes of CPR. That's a non-survivable injury by all guidelines, if it's due to trauma, right? So if she truly was down that long, like EMS, as we got to her, she lost pulses, we know it was 20 minutes, then I would just call time of death if there was no cardiac activity. And I would not offer a C-section. Now, if EMS comes in and they're like, I don't know, like maybe we lost pulses a few minutes ago, even 5 minutes ago, then I would probably move to C-section and then thoracotomy. And this is why you want 2 surgeons in the room, because one can do the C-section and one can do the thoracotomy. Cass is here, one of our PAs. She's helped me do some clamshell thoracotomies before. Sometimes, I mean, I can't be on both sides of the bed, right? And so having somebody else there who's comfortable can do all these sort of things and help us. We need an extra set of hands in these situations. 5 minutes to get the fetus out and setting up maternal closure bed. And if you think about it, like you have 5 minutes to have everything set up, fetus out, and into the warmer. So it's not a lot of time. And then also for us thinking about intraoperative C-section to allow exposure of maternal injuries, and that's where we probably call OB in to help us. And then these are just some of my references. Any questions? Yes?
What are like the tools you need at bedside to be able to do that closely in 5 minutes?
Scalpel.
That's all you need.
Yeah, honestly, to get down, that's really all we need is just some scalpels. You know, there's luckily the uterus stretches and skin stretches, and so in these situations, I would be making not the Thanet incision. I would be doing a vertical midline, 1, because I'm more comfortable with that, and 2, if they have to go to the OR, we could just extend it up to look at the spleen and liver and everything else. It's unfortunate because I'm not going to be looking at the uterus and be like, oh, it's got the good muscle right there, I'm going to flow, like something. We're just going to open it, right? And then deal with bleeding and consequences after that to get the fetus out. Hopefully by the time we had fetus out, OB would be down there helping us. Saying, okay, now we need to do this, let's get the placenta out, let's just get to the OR, let's do all these things. And they can take over part of the case and we can do the rest of the case. But honestly, you just need a scalpel and somewhere to put the fetus. And hopefully make you. Yes?
So you said it's hard to tell if there's been a uterine rupture?
Yeah.
And even like with all of the tests, so at that point, I guess it matters on the trauma whether or not you're gonna go and open her up.
So, it means like if we're taking the OR for uterine rupture,
Yeah, well, no, I guess it would be, if it's not related to that, if you're trying to rule it out, I guess.
yeah, so ruling it out could, let's say she didn't have any other indications to go to the OR. Ruling it out could be just monitoring fetal heart tones. And OBs honestly would probably be better at monitoring that, so I would prefer them to be on the OB floor, where the OBs can monitor them and they would have a better understanding of the signs and symptoms because they do see it from an induction side of things. Whereas for me, I'm like, I don't know what uterine rupture symptoms are, other than uterine tenderness. But when I was pregnant, if you pushed on me too hard, it hurt. So I don't know kind of where that line is. So that's where we really have to rely on the experts, which would be OB in this case, to kind of guide us. If we were going to the OR for another indication, like if I'm going to take out the spleen, you can bet I'm going to be down there looking at the uterus and making sure it's intact. And if I see anything that looks abnormal, calling in OB to say, hey, is this normal or is this not? What do we need to do about it? Yes?
So if it's like a non-traumatic pregnant lady giving birth, we usually send them over to FBC, like ambulance, but if it's traumatic, you want it in the ER.
100% we need to be involved.
To that,
Yeah.
and there's viable function.
Right?
Sometimes we send ambulances to you, but.
I think these are the nurses right here.
I don't wanna see a C-spine, no.
Yeah, they should come to us, like if it is trauma, and if the patient, it actually doesn't matter viability, right? Because if it's trauma, if the patient comes in as a trauma, we need to be the first ones called. If they are just also happen to be pregnant, then, you know, it'd be okay to let OB know, give them a heads up, like, hey, we got a pregnant trauma patient coming in, just wanted to give you a heads up. There's probably gonna be varying levels of interest on that depending on who you get, given this is a non-academic community hospital. But if the patient got here and I wanted OB involved, I'd have no problem calling them, hey, I need somebody down here to help us with this. But if it's a trauma patient, they're coming in for trauma and just happen to be pregnant, then we should be the first call.